Hello everyone, welcome to my YouTube channel. Today we are going to talk about refractory ascites and its management. So refractive ascites develops in about 5 to 10% of individuals with cirrhosis who have ascites and is linked to a poor prognosis. Generally, it is said that patients with refractory ascites usually die within 6 months. That is, almost 50% of patients die within 6 months of developing refractory ascites. It is defined as patient in whom there is ascites is recurring despite being on strict sodium restriction and optimal diuretic therapy. That means patient is on strict sodium restriction and also taking the adequate amount of diuretic therapy. Despite of that, if the patient is developing ascites, then it is called as refractory ascites. It is of two types: diuretic-resistant ascites, where fluid accumulate persist despite the use of maximum dose of diuretics. So even of using maximum dosage of diuretics, patient still develops ascites. Second is diuretic intractable ascites. In this patient could not take the maximum dose of diuretics because of adverse effects. So based on frequency, refractory ascites is defined as suppose any patient is developing the ascitic fluid, that is gross ascites, at least 3 times within a year, despite being on maximum dose of diuretic therapy or sodium restriction, then it is called as refractory ascites. So medical management of refractory ascites, the most important thing first comes is dietary sodium restriction. So sodium restrictions to limited to less than 2 grams of sodium per day is what is advisable. And this particularly is true for those who excrete around 80 millimoles per day of sodium in urine. So any patient who is excreting this much amount of sodium should be on sodium restriction, right? That is 2 grams of sodium, that means less than 5 grams of salt per day. And to quantify it, we can tell it as 1 teaspoon per day. It should be the overall intake of the salt by the patients of refractory ascites. Second important thing is fluid restriction. It is generally difficult and often not much useful in refractory ascites because these patients usually produce less than 1 liter of urine per day, making negative fluid balance unachievable with strict fluid limits. So the exact sodium level at which you should begin fluid restriction is unclear, but usually it is said that if any patient has a serum sodium of less than 125 milligrams per deciliter, then this patient should be on fluid restriction. Next important thing in the therapy of refractory ascites is the continued use of diuretics. In diuretic-resistant ascites, continuing diuretics offer very little benefit, and there is the increased risk of renal dysfunction. That means that usually diuretic follow this sigmoidal dose response curve, as you can see here. So initially, with the increase in dosage of diuretic, there will be a good amount of response in diuresis will be there. But after a certain amount of dosage is that is like 60 to 80 milligrams of furosemide or torsemide, then there is a steep there. That means that there is no further response which occurs. So increasing the dose further may not be very useful in those patients. Patients with cirrhosis have a lower ceiling dose. That means that at lower doses only, the patients develops the maximum effect. Increasing the dose further will not help anymore. So what is lower ceiling dose? Ceiling dose is nothing but the maximum dose of a drug beyond which no further therapeutic action occurs. So that means this is the maximum limit of a drug, above which no matter how much of drug you give, the effect will not increase more. So that is called as ceiling dose. So why is the ceiling dose lower in cirrhosis? In patients with cirrhosis, there is reduced renal perfusion, there is reduced delivery of the drug to its site of action, and there is activation of RAS and sympathetic system, which occurs in cirrhosis patient, and thus, and also there is impaired tubular responsiveness. So all these factors contribute to a lower ceiling dose. That means that the maximum efficacy of drug is reached at the lowest dose only, and after further dose escalation, there will not be any further effect. So usually in healthy individuals, the ceiling dose of furosemide is 80 to 160 milligrams, whereas in cirrhosis, it is 40 to 80 milligrams. Coming to albumin infusion, a study in 70 cirrhotic patients have shown that receiving 20 grams of IV albumin twice weekly, that is twice in a week, has associated with fewer hospitalization and lower mortality over 2 years or 24 months. Albumin appears safe and potentially useful, but still there are not much strong evidence, and also randomized control trials are required for this. The dose of albumin may influence treatment success and require further standardization. So, what the guideline says is that long-term albumin infusion cannot be routinely recommended outside of large volume paracentesis because of insufficient evidence. Coming to large volume paracentesis. Large volume paracentesis is defined as more than 5 liters of fluid is removed in those patients of refractory ascites and is preferred over ongoing high doses diuretics for refractory ascites. Repeated large volume paracentesis results in fewer electrolyte disturbances and renal dysfunction with survival rates comparable to diuretic therapy. Role of albumin during large volume paracentesis. So the guideline says that if any patient is receiving a large volume paracentesis, albumin should only be given if the amount of ascites being removed is more than 5 liters. So below removal of 5 liters of ascites, albumin is not required. After more than 5 liters, if we want to remove more than 5 liters, then for every 1 liter, you should give around 6 to 8 grams of albumin per liter of ascites removed. That means that suppose you have removed total of 5 liters or more than that, then you require 40 grams of albumin to be given. And if you're removing 8 liters, that is 8 into 8 grams, around 64 grams of albumin should be given. There is theoretically no upper limit. Always there is a question arise how much of fluid we can remove because there could be hemodynamic disturbances. So there have been incidences where more than 8 liters of ascitic fluid has also been removed. Coming to role of albumin during large volume paracentesis. Albumin should be considered even for smaller volume taps when patients have. Suppose these are the indications where even if you want to remove like less than 5 liters also of ascites, what albumin has is mandatory is when the patient systolic blood pressure is less than 90, serum sodium is less than 130, and patient is having acute kidney injury. Safety in coagulopathy, always their cirrhosis patient will have a prolonged coagulopathy is also found with prolonged PT-INR or prolonged prothrombin time. So always there is a doubt that whether we can do ascitic tapping in patients with coagulopathy. The answer is yes. So it is safe even with INR of more than 1.5 or platelets of less than 50,000. Only minimal bleeding has been reported. So INR elevation and thrombocytopenia are not the contraindications, and prophylactic transfusions are not recommended. Exception is patients having disseminated intravascular coagulation, patient with uremia with thrombocytosis. Coming to uh, surgical or intervention for patients of refractory ascites is called transjugular, that is means transjugular vein intrahepatic portosystemic shunt. It creates a low resistance channel between the portal vein and the hepatic vein. So they create a channel between the portal vein and hepatic vein, and this reduces the portal pressure and decreases the ascites formation. So these are what is its indications in refractory ascites is used when ascites does not respond to diuretics or large volume paracentesis. If patient is not responding to that, this patient has to be kept on tips. It is more effective than large volume paracentesis for long-term ascites control. Benefits: better ascites control, improved survival in selected patients with low MELD and younger age, reduces portal hypertension complications. Mechanism: lowers the portal pressure because of the shunt between the hepatic vein and portal vein, improves effective arterial blood volume, suppresses the RAS system and sympathetic activation, and do natural diuresis after 4 to 6 months. So most of the benefit is seen in younger patient with MELD score of less than 18, patients with good cardiac function and no severe encephalopathy. Coming to complications, hepatic encephalopathy is more common in patients with TIPS because there is the shunt of the blood from between the portal vein and hepatic vein and goes into the systemic circulation. Shunt dysfunction or stenosis and can also lead to cardiac overload in patients with heart diseases. Last point of therapy is liver transplantation. It should be considered in refractory ascites patients, particularly those not suitable for TIPS or with significant liver dysfunction. Patients with refractory ascites but preserved MELD scores may be disadvantaged since ascites adds extra mortality risk not fully captured by MELD. MELD sodium improves prioritization for those with hyponatremia. Hope you have liked this video. For more videos, keep watching our YouTube channel Infusion Medical and Education Zone. Thank you.